Good evening. Thank you so much for coming here on this very raw evening. So my name is Louise Hager, and as chairman of CHI, it's my privilege and pleasure to welcome you all here tonight. I'm also delighted to extend a very warm welcome to Dr. Xu, medical oncology consultant and associate professor at UCL Cancer Institute, and to Dr. Adrian Tuchman, chairman of CHI's medical advisory panel and a trustee too. We trust you.
Do you really?
We do. I don't know why. After all these years, not sure why. And of course, so many of our medical advisory panel. Thank you so much for being here this evening. It's really great to be back. This is the first in-person Natalie Shipman lecture we have had since COVID. When COVID came, we went online. So this is the first time we're doing it as a hybrid. We're here in person, and there are, I think, over 100 people at the moment watching us online. So welcome to everybody. I'm not sure who I'm told to look at. Straight, where am I supposed to go? Fine, okay. Just checking. So the format this evening will be that you're going to have to put up with me for a few minutes. I'm then going to hand over to Dr. Tuchman, who will chair the medical part of the evening. Dr. Xu will give us a presentation, and afterwards there's a chance for you to ask any questions you would like. There are slips of paper and pens if you prefer to write your question or ask from the floor. Great pleasure to actually formally introduce our newish CEO, Victoria Portnoy, who joined us in February. And as we say, has hit the ground running. And there's no other way at CHI, as all of you who have experienced CHI, how we work. We don't let the grass grow, we go very, very quickly. And it's been actually very fascinating to see CHI through new eyes. And we are learning very well to work together. Learn each other ways, a bit like an old married couple. We're coming up to our first year anniversary, please God, and no blows, all good, all good. So Victoria, thank you for everything that you're doing for CHI, and look forward to many more years of working together with you. We are actually currently supporting just over 4,178 cancer patients and their loved ones from this centre here in CHI and 10 satellite centres across the UK. And this year, just over 1,068, we've had new clients turn to CHI. Always say that with a very bittersweet feeling and emotion, because I know all of us feel there wouldn't be any need for CHI, but whilst there is the need, we are here with the most incredible team, dedicated, committed, passionate, driven to do whatever they can do to help everyone who turns to us. And I think it really is appropriate that we do really acknowledge this incredible, incredible team. We've got so many of our senior leadership here this evening and all the team here. This year, or the last 3 years, CHI has been very involved with our colleagues at Genetics in raising awareness of the NHS Jewish BRCA testing program. This is a unique, hasn't been done anywhere else in the world, population screening. And so far I can say there were over 41,000 people have come forward to request a test to find out where they have the mutated BRCA gene. If somebody does test positive, then they will be looked after superbly by the NHS. They will be monitored very closely. And CHI is here to support them to make any decisions they may make following a positive result, actually even to test them before to find. I have to say it's again, that we have developed many more groups in the last year across the whole, from Glasgow all the way down to London, and we just don't stop. We're going to keep going whichever way we can. You will find evaluation forms on your chairs, and we really would hope that you will fill them out, because that helps us plan for other events for the future and to hear what you would like us to do. So really it's a two-way relationship. Everything CHI does is to be the benefit of those who turn to us, but we need your feedback to tell us what else we could be doing. it is my job to try and secure that we have enough funding to keep going. So I'm sure you will understand why I'm just going to let you all know that we have our match funding campaign on the 7th and 8th of December, please God. It is called For All to See what we do. So it's hard to, you'll see it, believe me, you will see all the publicity to show the care, the compassion, the commitment of Chai and how we come together as a community. And it really is a community coming together to help support us. So if anybody here would like to have some more information about how they can get involved and how they can help us get to just over £4 million, which is what this will be our running costs, I bless you in advance. So please come forward. The advantage of doing this hybrid is that obviously people are joining us from all over the world. So we know they are from Europe, from America, from Canada, and especially from Israel, where Susan Shipman, who's Chai's founder president, is joining us. Susan, send you all our love. Tonight today was Natalie's 35th yard site. It's hard to think of 35 years going by because I still think of her as this little girl, this wonderful little poppet who was one of the inspirations for Chai and what we do today. And she really was the catalyst when my mother, who co-founded Chai with Susan Shipman, met on a very hot June night. Natalie was just a few months short before she tragically passed away just before she was 8, having been diagnosed with a brain tumor just when she was 3. And there was this little puppet sitting in the wheelchair, and this little voice came up and she said, I want to do whatever I can to help you. And without doubt, we think of her, we think of my mother who co-founded Chai every day, I think, because it was the heart and the soul and the devotion that got Chai started from nothing, from absolutely nothing. My mother and Susan created this incredible organization. And just thinking of them, when it gets tough, when sometimes the work seems a little bit of overload and we're not sure how we're going to go forward, we literally think, why did we start? What's behind Chai? Chai, the Hebrew word for life. And whilst neither of them are here physically in this world, they are actually living in some very, very positive way throughout the whole organization. So Susan, we send you, I'm not sure, am I looking up? I should look straight, right? Straight or up? Straight. Thank you. So that light is, Susan, we send you our love. We wish you long life, you and all the family. Thank you for what you started with all your devotion and heart. And we can't wait to see you in person. So now it's my great pleasure to introduce Adrian Tuchman. Adrian Tuchman, he can't get up yet, is a palliative medical specialist. He qualified in 1976 and was appointed in 1985 as a palliative care medical consultant to the Royal Free Hospital and medical director of the Marie Curie Hospice Hampstead. He was appointed as medical director to the Royal Free Hospital in 2005 and served till 2009. And he retired from clinical practice in 2021, but continues his many charitable activities. You have been an incredible friend to Chai, and please God for many, many more years. Adrian.
Thank you. And can I just say, Louise, the amazing work that you've done. I mean, I remember we've worked together now for how many years?
32.
Yeah, it's scary, isn't it? So we worked together a long time. Louise is, as everyone knows, a fantastic lead, a fantastic example for us all. So Louise, thank you. Thank you. And I'll be very brief to do the introduction. Actually, 35 years. Kai King, when were we working together first? How many years ago was that?
An SHO, so it would be like 2003.
So as you can hear, I've known Kai King for a long, long time. He used to work for me.
With you?
Oh, got it?
Got it.
Got it. And so we go back a long way. And thank you so much for coming today. Thank you so much for coming today. And actually, thank you guys for coming today as well. This is the first one, as Louise says, that we've done since the COVID time. face to face, and it just feels so good to have the people in the room that we can sort of communicate and we can work together. So I'll be brief because I'm sure you'll tell more. So Kai Keen, as you know, consultant in GI, gastrointestinal oncology, clinical lead for the cancer and of unknown primary service at University College Hospital. He qualified at Guy's and Thomas, but that was a long time ago. But the important thing to say is his research activity has been, and I'm sure Kai Keen is going to tell us a lot about that. The research activity is going to be a little bit about that. Has been phenomenal. He's a well-respected individual. So, Kai Keen, thank you so much for coming to talk to us, and please enjoy and please ask questions afterwards, as Louise says. Thank you.
Very kind. So thank you, Adrian, for that very kind introduction. Thank you to the High organization for I heard this is a huge honor, and it's a huge honor for me not just to talk to some of my colleagues, but I know there's some patients of mine in this room, and of course to Louise and Victoria for prepping me for this. So Adrian doesn't really do that, so is that how I know him, but maybe at the end I can tell you some pithy reminders of how he set me on my career, but on my career path of oncology. But I've been asked, well, I would like to talk about bowel cancer. I treat all cancers actually in the GI tract, so gullet cancer, stomach cancers, biliary tract, pancreas, appendix, bowel. But I just want to use bowel cancer as a really good example of where we are really at a crossroads and an exciting crossroads of how we're going to treat our patients and whether we are thinking outside of the box. We're certainly thinking outside of the box for bowel cancer now, but equally you probably read it in the news all the time about this, why are younger and younger patients getting bowel cancer? And of course, through the Jewish community, we've heard about BRCA mutations, and you've probably heard about Lynch syndrome. But we're really worried now because we're seeing younger and younger patients, not just under 50, but now in their 30s. And I'm just thinking about like 8. So I've just had a call about 11-year-old, Josh. I've had a 6-month-old baby with metastatic bowel cancer. It's not right, So I'm going to say something is very, very wrong, and it's not clearly genetically driven. Okay, so I'm going to talk about, and I've been asked, I think you want to talk about diet and exercise and all the things. I'm going to bring that all into play, and also what we're actually trying to do about it. So this is me. This is called a circa plot. Okay, so a circa plot is essentially, you've got chromosomes, 23 chromosomes, and basically that shows what a circa plot is. Unfortunately, in my lovely laptop here in 4D, you can see lots of mutations. So this looks very beautiful. And this, I don't know what kind of tree you think. This is a banyan tree. Okay, so I'll bring it all together why I've got a circa plot and a banyan tree through my talk in the end. So the overview is that we know that bowel cancer is on the rise. It's potentially up to the 2nd or 3rd most common cancer to get. Ooh, what's going on here? And definitely the younger generation, as I said, under 50. I'm going to talk about important signs that you should be looking out for, whatever age you are now, what you can do to reduce risk. Okay, trying to cut through all the stuff that you see on the intranet or internet, and what we're all trying to do as a global community to understand why and what we can do to prevent it. So again, just to keep it really simple, this is your GI tract. It's from the mouth to the anus. I'm going to focus mainly on the bowel here. Okay, so that's your appendix, your favorite appendix. That's the start of your large bowel, ascending, transverse goes across, descending into the rectum and into the anus. So we know that we are missing cancers, all right? You've probably heard about people having scopes, fecal occult blood testing, things like that, but we are missing cancers, okay? And especially in the younger population where we are usually dismissed as having IBS or hemorrhoids. And of course, as oncologists and as palliative care physicians and things like that, we see it at the pointy end, which means that the patient's already been diagnosed with cancer, but the patient's been living with the cancer for a few years, and then probably either ignoring the symptoms or someone's been ignoring symptoms, and then, oh, now the cancer's too late, okay? So this is just some statistics, which is quite old from Cancer Research UK, but still about right, 45 to 50,000 cases a year, approximately 120 patients a day are being diagnosed with cancer. And the rates in the under 50s increased by 52%. Okay. This is not just a UK thing. So although I'm showing, so this is the increase in the under 50s, this is the standard. So we're seeing this as a kind of almost tidal wave across the world, and it starts in America, okay, and it kind of, we think it started in the 60s. Guess what happened? Post World War II, affluence, probably diet, eating, and we're seeing it across everywhere. So it's not just the Western world, it's now in Vietnam, in Ethiopia, in India, and in China, and now Japan, which you think would be one of the healthiest people in the world, but the diet's changing. So again, I know we were talking about diet, there probably is more than just a figment of imagination. So people say it's diet, and I used to say no, but it is something probably about what we put in our bodies. So really basic things about this comes into the screening. How do bowel cancers grow and spread? It's one of the most preventable cancers in the world. Okay, if you scope someone and you see a polyp, you remove it, you're already probably saving lives. Okay, so it's one of those few times, although a colonoscopy is not fun at all. I've had about 3 or 4. It's the bowel prep. Okay, have you ever had one? It's the bowel prep that's a killer, not the scope itself. So the fact is that you can have a little polyp, and then that polyp may be removed. If it's not removed, it could penetrate the first part of the bowel wall. If you're unlucky, it goes to the middle of the bowel wall, but it doesn't involve the lymph nodes. If it's less good, it penetrates through the bowel wall, and then you start getting spread into the lymph nodes. So that's called stage 1, stage 2, stage 3. At any one of those stages, that's still curative if you can remove it. Okay, that's really important. But you can also imagine the further it keeps on going, the uncertainty principle comes in, right? Because you could remove it all, you might be cured, but there might be microscopic cells in the lymph glands or the bloodstream that can go and cause mischief. And we also know that the bowel is now a continuum, okay? So it's not just right side, left sided. It starts at the appendix, and this is just to show, sorry, lots of genetic mutations. Okay, I don't want to scare you, but every cell in your body has got a mutation, okay? It's whether how your body copes with it and where it eliminates it, all right? So we also now know that, I mean, as you probably know, all cancer has a genetic component to a part of it, okay? But I'm going to show you that it's got to be more than just your genes. So very quickly, again, just some basic knowledge. Well, we had fecal occult testing for decades, and it wasn't great. The reason is that it was just looking at kind of altered blood or just blood on the tissue, that you could still get a positive occult if you had hemorrhoids. We moved to something called FIT testing, okay? And this is very important because much more specific. It only looks at blood that's altered. So usually, you know, if you think about your tumor here, yeah, you kind of digest the blood, okay? And then it only picks up blood that's kind of digested. And what's really interesting is that that is a way of screening the population and then offering a colonoscopy. I'll tell you what's really interesting is in 2021, before COVID, actually, we had planned this. Then COVID hit, and post-COVID, remember, or during COVID, people weren't being scoped, right? Everything shut down, okay? And so we have had this aftermath post-COVID of gastroenterologists saying, wow, we're just seeing more and more patients when we're scoping them for screening that actually have got cancer because we've missed them 1.5 years, 2 years ago. Remember, COVID does not cause cancer. So there's a lot of stuff in the news about COVID. It does not cause it. But I do think it's associated with that rise, okay, because we weren't screening them, we weren't scoping them. A positive thing about FIT testing, it moved FIT testing from the secondary care. That means that you could only do that if you went to a surgical clinic, a gastroenterology clinic, a nurse-led clinic. Now a GP can do it. So just to remind you, if you don't have, I don't see many under 30-year-olds, but you can actually ask for a FIT test from a GP at any age now. I mean, GPs have to just be bothered to do it. You might not get a colonoscopy, okay, but you can get a FIT test. So it's quite helpful. Oh yeah, and so the other thing is that right now we are not scoping people under 50. Yeah, it's 50 and above. But America has led the way, and Canada is leading the way, and I think Israel now as well is 45. I think 45 and below. I'm going to show you that may not also be enough, okay, in terms of the age when you start scoping someone. So again, really just so that you understand what we're looking for, what you're concerned about, and the most common things are, I explained anemia. Now, of course, that would be a blood test, but you're anemic because you're bleeding from your bowel, okay? So it's going to be bleeding, okay? So you've got rectal bleeding, and don't just say it's hemorrhoids, and abdominal pain. Those are the most common things, actually. Weight loss is very late onset. If you're losing weight, that means unfortunately it's spread too far. But really common thing, so abdominal pain and bleeding are not normal. Okay, weight loss and tenesmus, all these things are usually when things are already a little bit too advanced. And when it really, really advanced, unfortunately, bowel cancer is often spread to the liver. So you can get abdominal pain and jaundice. It spreads to the lungs. You can get breathlessness. And unfortunately, when it's very, very late, it can go into the bones. And very now, rarely, it can go into other parts of the body. On most of the time, it's unexplained. So it's usually a test, right? So the GP says, come in and have, I was turned 50, so I got my, and I already had colonoscopy for 10 years. But, you know, so I think if you do have access to a GP who says, just come and get checked, often a lot of things are incidental, right? And then you trigger the investigations. So now here's a bit of like, wow, and I don't know really how well this projects. It might be better online. But all I'm just saying is that bowel cancer is genetic disease. The biology is more complex. So one, we have this idea that we have mutations, and there's a very small subgroup, okay, usually 10 to 15% of patients are hypermutated. And these patients are something called a deficiency of mismatch repair. So again, I know you know about BRCA, so BRCA1, BRCA2. I always was taught by Anna Natalie, my PhD, because like four legs of a table, you lose a leg, you know, you try to hit it with a PARP inhibitor, you make the table fall down. It's similar actually to MMR deficiency. You think of MMR deficiency, there's 4 genes, okay, it's something called MLH1, PMS2, MH2, MH6, and they repair your table legs or chair legs. And basically, if you lose a gene, yeah, when you repair yourself, you kind of repair it, but like with plasters, and it's all wobbly, and then you just like the tables can collapse more, and you just keep on collapsing, and then you get hypermutation. So you get lots of broken genes, and then you get lots of instability, and then you get lots of hypermutations. So we know that that's bad. Okay, sorry, it really doesn't project well. So there's a group of hypermutated cancers, and they, if you think of lots of mutations, a bit like in lung cancer from smoking, melanoma from sunlight, BRCA mutation, okay, inherently from your genes, you're more likely to get a cancer. And those cancers are probably a bit more aggressive and resistant to standard of care treatment because they're so mutated, they become resistant to a lot of the standard of care treatments, particularly chemotherapy. Having said that, we've unpicked some of the genomic it's called a PI, okay, and we call something called KRAS, NRAS, but you've probably heard, because of a lot of the news, BRAF mutations are bad because the BRAF babe, you've probably heard about that in the news. And so we really worry about the BRAF mutation, and these are small subtypes. And we combine it with gene expression profiling, and we combine it with our clinical knowledge, and we can kind of subgroup these patients saying, right, this is how we can manage these differently. But this is almost when it's too late. Okay, this is already when the patients have got quite advanced disease. We've always tried to say, you know, I did my PhD with Anna Ashworth and said a gene function lab, and we always said, where is the magic gene? There is no magic gene one. I mean, we, of course, BRCA1, BRCA2 is transformative, but very, very few genes that like, that's the panacea, that's going to kill everything. Okay, so I like this one because I used it during my PhD. It says, we think we found the hub1 gene. What does that do? It determines the level of hubris. Basically, because you think, yeah, that's the way it's going to go. I'm going to get all my research funding that way, but it doesn't. Life is not like that, and certainly cancer is not like that at all. It's much more complex. And I don't want you to read all these lines, okay? But what I'm saying is that I don't know who was born in 1980, but when Daniel Hockhauser, my other mentor, was born, when he was practicing, he had the Mayo regime, which was basically giving one drug called 5-fluorouracil many different ways, okay? Basically, one drug given lots of different ways to work out whether it would get better. Pretty dire, okay? And then we've got all these chemotherapy drugs and all these antibodies. But to be honest, it's only really for about 5 years onwards where we've added in immunotherapy, which I'm sure you've read a lot about in the news, basically trying to boost up your own immune system to recognize your cancer cells as foreign and use your kind of superhuman, charged immune system to kill the cancer. And you not just get shrinkage, but you get durable responses. Remember, immunotherapy, the joy is that it is both adaptable and it has memory. That is why people you hear immunotherapy go into remission with stage 4 disease, such as melanoma. Okay, so melanoma, again, an increasing tumor in the young because of sunbeds, sunlight, tourism, things like that. So I had one of my friends in medical die of melanoma during medical school. You know, died in it within a year, went to America, tried everything. But that was before we really got immunotherapy into gear. Now, there's about 50% 10-year survival for advanced melanoma. Amazing. What I'm also going to show you is that although we're now also giving immunotherapy for advanced disease, which is much better than chemotherapy, we are now using immunotherapy in what we call the neoadjuvant or preoperative stage. You know, I talked about the stage 1, 2, 3 cancers. In certain cancers, we are trying to push preoperative treatment. You hear that in breast cancer, you hear now in lung cancer, certainly in bowel cancers now, we can use it. And I think the other really important thing is we have to work as a team. So I'm a medical oncologist. I give lots of drugs, some expensive, some so much. But none of this I can do without a team. And that team, this is a very old slide, when pre-COVID, when we were all together, there's, I think, Daniel Hothouse sitting at the front, as he always would do. The surgeons at the front, because they always do that. And then we've got some students at the back when we used to have students. And then we have radiologists, students who care and come in, who actually come in and see us at UCL. We've got a radiologist here, a pathologist here, a nurse specialist here, and we all discuss these cases. And so remember, drugs are one thing, but surgery has a role, radiotherapy has a role, very, very technical radiotherapy, including protons, has a role. So it's all about working as a team. So this is maybe, I'll tell you a story maybe later, how Daniel kind of gave me this trial, but I was a new consultant, and this was a trial called Keynote 177, and it was giving pembrolizumab instead of chemotherapy for patients with stage 4 inoperable, incurable bowel cancer. I'm sorry, it really doesn't project, but basically it was a major change because it's the first trial that showed that you could use immunotherapy instead of chemotherapy to treat a particular type of MMR deficient bowel cancer. Rare, only 5% of the population, but you can see, hopefully, this is called 5-year survival. Normally, if you look at the CHO website, 5-year survival for metastatic bowel cancer is about 10%. It's pretty sad, isn't it? 12%. So now we've got patients who have on immunotherapy where more than half of the patients are still alive at 5 years, okay? Why the group that had chemo first doing quite well as well? Because in this trial, they had chemo, and if they progressed, they actually had immunotherapy. So basically, as long as you got immunotherapy, you would live longer. I think the other really transformative thing, which I can't show you here, is that about 30 to 40% of patients, all they had was this 2 years of immunotherapy, and they're still in remission. So we are thinking that one drug could at least about 34% just be enough to keep them alive and forever. So one of my loveliest patients, who's now in the Daily Mail talking about it, is I think at 9 years, and actually unusually she only had 9 weeks of immunotherapy, and it triggered a fantastic response. So she's clear, right? She's in her 70s, not the fittest woman in the world. So just 9 weeks of immunotherapy has put it into remission. This is why it's a game changer. And that's why people want to be on immunotherapy. That's why everyone says, give it to me. Okay, I want it, I want it. So this is a trial I've also done called NeoPrism colorectal. So neoadjuvant preoperative pembrolizumab in stratified medicine colorectal. So using that principle that in that one patient who taught me that maybe 9 weeks of immunotherapy for stage 4 cancer could put you in remission, how about just 9 weeks of preoperative immunotherapy? So these are patients with nasty stage 2, stage 3 cancers where normally we'd give them surgery followed by 3 to 6 months of horrible chemotherapy, but they're ML deficient. And using that data that we learned from stage 4 disease, I said, right, let's just give 9 weeks immunotherapy. And basically, it's a fairly simple trial. You either give 3 or 1 cycle, chop it out. But what's really important, I was trying to learn from every patient. So Adrian was talking about teaching and research. So I want to learn from every patient. Just a small trial, just 30 patients or more. But what I was doing for these patients, and they were very nice because I enforced them to all have an extra colonoscopy. Yeah, said that it's for the science, just do it for Dr. Shu. But this is across not just one site, this is across 4 sites. Anyway, we did lots of biopsies, lots of blood sampling, and you've again heard of probably how you detect cancer in blood. So we wanted to profile that. And also, very importantly, and is important in the second part, about microbiome, okay? Because I think, again, another thing that I've heard that you want to talk about is what can I do about my gut microbiome? So I was interested too. I don't understand it at the time, but I said, yeah, I think there's something about your microbiome that either makes you get the cancer or makes you change, and maybe it would trigger biomarkers. So what we're trying to look at is how a lot of patients say, look, I don't really want to know how long I live on average. I do want to know that the drug you give me is going to work, okay? Ideally 100% of the time, but at least give me a pretty good idea. So the good idea about these neoadjuvant studies is that we do the biopsies of blood samples before we start a treatment, we give them a window of treatment, and then we obviously do another biopsy. So you can learn a lot very quickly in 3 months Whereas previously, if you just chopped it out and then you gave them some drugs, you may take 3 years to find out whether it worked or not. So this is accelerated kind of understanding biology. So we were basically looking at how well the cancer completely melted away. Okay, this is how confident we were based on some other studies that it would completely melt away. So that's the most important thing. So I'm just going to show you one example. Sorry, this is probably another gory picture, so careful if you don't really want to look at a nasty bowel cancer. I want to learn from every patient. This is a patient who was on the study. He's only 47 years old, so under 50, presents with pain and anemia, but no symptoms of bowel obstruction. Very strong family history of cancer, so probably something's going on. And it was eventually found that he had Lynch syndrome. But anyway, had a really nasty tumor. It was bleeding, really bulky. And you can see, hopefully, this is a CT, and this is a really bulky tumor. Darren is in the room, so you'd agree that this is a really bulky tumor. It's like touching the side wall, lots of horrible lymph nodes involved. So we've got him in the trial. We do some profiling, which I won't really go into today. But basically, we give him a therapy, and he's actually feeling a lot better off within, I don't know, 3 weeks. It's not anemic. Then he gets pain, and we tell him to come in because he's going into bowel obstruction. Why? Because the tumor actually is melting away so quickly. Okay, it's actually called a stricture, right? So the tumor just melts away so quickly that he's narrowed the bowel and he goes into obstruction. And actually, although he didn't have a complete response, okay, he had a very near complete response. And probably if he didn't go into obstruction, he would have achieved a complete response. Tiny bit of residual tumor just in the surface of the bowel, and he had just one lymph node involved. Okay, we offered him, because he's only 47, adjuvant chemo. He says, nope, Dr. Xu, I came in the trial because I didn't want to have, I believe in you, I didn't want it. And he made the right decision, because actually now, almost 2 years, he has remained relapse free. So we don't know he's cured, but he's definitely had very good treatment here. Now, I don't know whether this is going to come out very well. So what I showed you was that we do lots of translational work. Okay, so from the biopsies, we can do these kind of genetic profiling. We can do the whole genome profiling. We can do something called circulating tumor. Again, you may be heard in the news about detecting these tiny fragments of cancer that tell us whether you need chemo or not chemo, or you're responding to treatment, not responding to treatment, or even making diagnosis of cancer. We look at something called TCI diversity. That's the idea that, remember I told you that that boost up immune system, you need these T cells, okay, to kind of boost up. So there's something about the engagement of the tumor to the T cell that tells you whether you respond very well, because T cell clonality. We looked at the microbiome, we looked at the microenvironment, and this is very cool. This is called organoids, okay? So we don't use mice, rabbits, monkeys anymore, which is a good thing, okay? We don't use cell lines. They're a bit good, but they're not very good. We use organoids. So organoids is a way of growing from a biopsy, a kind of a mini me. We'll talk about what it really means. But basically, you can grow it within an environment where you can test it hundreds of times. So from one biopsy, you can split it into hundreds and drug these little organoids forever. Okay. So that patient, remember that patient who hadn't got quite a complete response. So in that trial, this is my PhD student I work with in the Janssen lab at UCL, Monica. These cells, sorry, it doesn't project very well, are cells that were grown from, I can't remember if it's on the original biopsy or on the residual tissue. And so we've got these paired biopsies, right? So we've got some tumor from the beginning before you had a drug, tumor at the end after you had a drug, and then you can test them in multiple ways, millions if you want, ways. And that's so helpful and really interesting. And these are living things which you can just split, and then test your theories. So I'm almost at the end of the talk, because I'm really interested in your questions, and I want to have an active guide. So I've talked about some really cool things: stage 4 disease immunotherapy, early stage immunotherapy. But isn't it better to not get the cancer in the first place? Preventive is better. So, okay, can we use vaccines? Yeah, that's a dirty word in America at the moment. Okay, I hope it's not projecting to Donald Trump and Robert Kennedy, but vaccines and immunotherapy to prevent cancer. And we've talked about Lynch syndrome, and this is a very good model. Lynch syndrome patients is like, it's a battle zone in a way, because they were almost definitely going to get cancer. It's a bowel cancer in a man, but it's also, you're at risk of getting other cancers in women, endometrial cancers, ovarian cancers. So what we've tried to do is say, look, we really want a dedicated clinic for patients either with Lynch syndrome or early onset bowel cancer, to try and get these patients access to newer treatments, better treatments, and and understand that better. Okay, and we want them to have access to trials and studies. So we've talked about some risk factors, but I'm going to specifically talk about early onset because that's what we're worried about. It's not that I don't care about my 60-year-old patient or my 70-year-old mother or my 80-year-old grandfather or any of that, but I think it's really interesting, and I'm really sorry this does not project well. It's not rocket science. We know what's bad for your body. You probably shouldn't eat a lot of fat, processed food, you know, refined sugars, drinking loads of alcohol. We know that's not good for you, right? But we still do it because it's fun, right? And it's good. But I'm not saying you all need to be a monk or a nun, but we know what's not good for you, right? Exercise is good for you, right? You know, of course it's good for you. So the fact is that in a young patient, a lot of these things, it's interesting. We did a survey of patients with Lynch syndrome, young adults, and we said, right, you know that losing weight is good for you, not drinking is good for you, exercise is good for you. They said, yeah, we know that, but we've been told that, you know, whatever we do, we're going to get cancer. So who cares? Because there's no. So that's not obviously. I don't want you to come out saying that they don't care, but it's really, really worrying. But people who without, I'm going to show you, people without Lynch syndrome, we have to really care about this. Because why are patients who are in their 30s getting cancer? Cancers don't develop overnight. They do over 3 to 5, even 10 years. Okay, so we want to try and understand this accumulation of changes. Life, yeah, we've got to live life, but we've got to live life well. So it's called an exposome or exposures. Okay, you think about exposures. So again, I hope so these are all theoretical. So please don't come and say, "Oh my God, you know, I didn't do this when I was, you know, I didn't do this to my child," and please don't do think about it. But there are concerns around breastfeeding, diet formula, using a lot more antibiotics, okay, when in your children than what you didn't used to do, okay. Mode of delivery, okay, and there's something about ingesting your mother's poo. That's probably quite a good thing as you're coming through the vagina. Stressors, antibiotics, how much you had, and all those kind of things. Then we've got exposomal, which is what you do to yourself when you're a baby or when you can have choices. So westernizing diet, unhealthy cooking practices. What do I mean by that? Well, really simply, okay, is if you fry things, if you grill things, you know, it's like you've got black stuff. It tastes great, right? Yeah. But if you have it every day, like some people in Australia do or South Africa do, then it's probably not good. Processed meats, that means sausages, which are not natural. Frankfurters, not natural. Eating every day, not great. Synthetic dyes, maybe MSG, loads of things. Okay, then you've got what happens is that we think that there's a trigger, and I'll show you some triggers of it. It basically alters your microbiome, and then your microbiome has interactions with your own body. So this is about lots of interactions, and then you get cancers. Now, this is a kind of cute picture, but this is actually all retrospective. So just again, before you're scared, this is retrospective, not prospective. Okay, so it's association, not cause. But definitely showed, okay, there are certain things that cause these certain foods are basically metabolized by certain bacteria into sulfur-containing compounds. Processed meats, low-calorie drinks. These are the drinks that your teenagers or teenagers are drinking. You remember all these drinks they have sports and they think they're sports drinks. Liquor, okay? Not wheat beer, apparently. Wheat beer is good for you. I don't know, in Germany it is. But liquor means like whiskey, you know, sherries, processed things, okay? And others are less, okay? Now, yeah, okay, I'm not gonna. So the concept is that I'm sure, sadly, you've heard about hydrogen sulfide. It's like mustard gas, World War I, yeah, gas the Somme. And lots of soldiers in those days got cancers, leukemias and cancers. So you've heard about smoking. Now, this is one theory, by the way. Don't come with that. Dr. Shu says that this is the way to stop me getting cancer. But you've got to think that we know that smoking's bad for you, right? You smoke, all the carcinogens, the nicotine, smoking your lungs, you're getting lung cancer. So this is the concept of smoking your gut. And this is not just your bowel. This is your esophagus, your mouth, your stomach. You know. So the idea is that you're ingesting things, okay, that your bacteria are fighting against, okay, but they're making hydrogen sulfide. So you're kind of gassing your bowel over a number of years. And it's probably 2, 3, 4, 5 years. The other thing we know is that certain bacteria, actually, this is quite scary now, can cause mutations in DNA. Isn't that scary? A bacteria can cause a genetic mutation in your own DNA. That's how toxic some of these not just E. coli, certain types of E. coli, which I'm sure you have. So what can we do about it? It's really difficult because actually it's hard to do trials in this, all right? What we've shown is that there's something called C. diff, which unfortunately surgeons will know about, and we don't know about. You give too many antibiotics and you get these horrible bacteria, and you can do a fecal transplant. That means you can transplant someone who is essentially doesn't have C. diff into someone who did have recurrent C. difficile and colitis and dying, and then you can make them live longer, all right? The concept in immunotherapy is that we are now doing trials of patients who've got, remember, to melanoma. So melanoma, we've now got patients who are resistant to their immunotherapy. You give them a pill, or you can give them a fecal transplant of a patient who responded to immunotherapy, and lo and behold, they respond to immunotherapy again. So what I'm saying is, in the old days, I said, yeah, whatever, the gut is like pseudoscience, it doesn't make sense. And all the nutritionists were probably right. You know, we probably should look after our gut, okay, a lot more. It's an actual organ, right? It's a huge organ, and we should look after ourselves. That's why I was saying you can think about probiotics, you can think about diet, and we talk about that, and we can think about targeting detrimental microbes. So, you know, I talked about certain bacteria are very bad for you. We know how to target certain bacteria. And why don't we give them antibiotics to target those bad bacteria causing mutations? Almost there. So we need consensus. And it's really interesting. It's only in 2023, this 2 years ago, despite the fact since the 1990s, we saw this coming. I think all the epidemiologists said, it's coming, it's coming. And I think as oncologists, and I know there's some other in the room, you kind of felt something wasn't right. Okay, it's like, So when I was Daniel Hockhauser's registrar, I remember it was very rare to look after someone under the age of 40, you know, with bowel cancer. It's just full of patients now in their 30s and, you know, with advanced disease as well. So the idea is that this is a consensus of, I think, lots of organizations and about 69 people trying to work out what is the really important thing. So understanding how to make the diagnosis, understanding risk factors, doing the genetics, which I haven't talked about too much apart from M1 deficiency, but there are some other genes that are associated with bowel cancer, doing the special genetic testing, understanding the therapy, doing high quality endoscopies and supportive care. So this is kind of like, I think, basic stuff. But what I want to really talk about is what we're trying to do and emulate. Some centers in America have been doing it very well, led by this fantastic oncologist called Kim Dana-Farber, but it's done at Sloan Kettering, MD Anderson at Cleveland. And the idea is to have these specific programs for early onset. Again, I know I'm talking about early onset. You could say, what about my 60-year-old and 70-year-old, 80-year-old mother? There is also that. But I'm saying these are very specific because they have specific needs, okay? Particularly around not just the toxicity of the treatment, but there's financial toxicity. They've just got their prime of their life. They've maybe married with children. What are they going to do with their jobs? Fertility, we're not really good at talking about sex. Okay, I tell you what, and as a GI oncologist, I'm not a prostate oncologist, I'm not a breast oncologist, I'm not a gynecologist. I don't really talk about it, but they want to talk about it. Okay, and we need to kind of talk about that. So there is no dedicated pathway, as far as I know, though Imperial is starting something as well, I know, for patients of young adults with gastric cancer. So just imagine, I think someone was talking about a 35, so this is recently a 38-year-old young child recently died of bowel cancer, unfortunately passed away recently, but, you know, really had almost no time with the child, but they present late with more aggressive disease. They face fertility loss, employment disruption, they have children at home, they have less access to what we call age-appropriate care, okay? We can probably change that story of dedicated services. As I said, this is a real opportunity that UCH is going to do, and I'm going to thank my senior research fellow, Evelyn Wong, who's come over from Singapore specifically for Singapore to help me set this up. So we've called this Genesis, okay? Gastrointestinal Early Onset Cancer Service. Very important, this is a service, but we're going to innovate, okay? The vision is, of course, we want to improve survival outcomes for our patients. That is what we want to do. And our mission is to, first of all, set up a comprehensive, maintained database. So often what you talk about databases is that you do a database and then you leave it alone on a dusty shelf, technically, yeah, in a server, and then you might just delve into it a little bit when you've got an idea. We want a living biobank, a living database, and we want to use that to collaborate with those centers around now the UK, Europe, and across the world, and increase also general awareness and education. So this, again, really doesn't project well, and maybe it's a bit too ambitious, Evelyn, but we have a pathway of how we want to get these patients through our system. But the whole idea is integrated, okay? So we have integrated care with what we already exist, but we identify these patients. And what the idea is that, let's say you were referred to UCH as a person under 50, internal ascending, we would have a carer who would actually ring you up and says, hello, you're going to see Dr. Xu and his team next Tuesday. Would you like to be involved with this program? And upfront, you can get extra genetic profiling. If you're interested in your stool samples, we can take that. We're going to give you some extra help around clinical trials, psychosocial help, fertility, all those kind of things. So even before you step into the building, almost in the clinic, you've already kind of signed up, and we can move on from there. Because often what happens, and oncology will know, you see them too late. You've seen them after everything's happened, right? And it's not just building in the CNSs. We have research assistants who will come and say, look, you know, are you happy now? We're going to take a blood sample at the same time, take a stool sample. And so that idea. Then we've got the tailored support, which is obviously around fertility, counseling, and family screening. This is the research, you know, where we want to go in and access clinical trials and innovate. Okay, so Evelyn has done this fantastic tool in Singapore where she created during COVID a way to young adults, because they engaged on their phones, right? That's how they engage, right? So basically, they don't want to tell people all their things like in life. So they can tick, they love clicking things, right? So they say, yeah, I have this problem today, I have that problem today. And you can build up this amazing toxicity profile of what they're really living with. So, because this is very common, right? Patients come to clinic, they, and I lived it with my mother, she would lie through her teeth how bad the treatment was. So she was so concerned that oncologists or hematologists would not treat her that week. So I knew she was vomiting all over the place. She had diarrhea. She'd lost all her hair. She'd lost all her dignity, but she still got dressed up, you know, for her treatment. And it's a bit like that for our patients, whether they're young or old, right? They're so petrified. But this is reality, and a lot of these treatments are toxic. So this is, as I went from tailor to tailor. So this is just the idea. Remember I told you that you can grow little avatars and things like that. So we have set this up across the board. So we talked about colorectal, but we can do this for almost any cancer, to be honest, all right? Whether it's ovarian cancer, breast cancer, pancreatic cancer, which is very difficult to treat, esophageal cancer, we can create these mini organoids, derive them, and we can work out how we can make them, how drugs work better, because that's generally what people want to do. And there is a thought that eventually we'll get it so good that as you get diagnosed with cancer, whether it's early stage or late stage, in parallel, okay, you can drug a tumor alongside it. And maybe you can have this real life avatar personalizing you drug them and said, this is the right treatment for you, or I don't need this treatment. Okay, so this is very, very exciting. And this is funded through the CROK and UCL through my fantastic colleague, Chris Tape at UCL. So we can talk about that later. But the whole idea is that things are really moving very quickly forward, and it's really exciting times. So this is, I think, my penultimate slide. I have run over a little bit. I hope you've enjoyed it. So I told you there's many mentors in my life, but there were two main ones. Alan Ashworth, who was a scientist and discovered BRCA2, and Charlie Swanton, who there's this thing about tumor heterogeneity, that tumors are just so different within one tumor. They were both into cancer genetics, said that is it, genetics is the way to go. Then this thing called immunotherapy came along and went, oh no, well, immunotherapy is genetic as well. So they called it immunogenetics. So immunology is still genetic. And this is an idea, actually, of this. You can use it for any analogy, to be honest. So you've got the palm tree, you've got the chestnut tree, you've got the baobab tree, and you've got the dying muhly bush. So the idea is that there are certain tumors that are really simple to treat. They have one way that they grow. You can chop them in one go, and they cure. A little bit like testicular cancer, I would say. Certain lymphomas, even certain leukemias. Most solid tumors, unfortunately, is horrible, are chestnut trees. You've got a big trunk and all these branches, and you can prune off the branches, but they still grow. And then they start kind of growing a bit mutated. And sorry, it wasn't a banyan tree, it was a baobab tree. But you can say, okay, it's getting more and more mutated. Okay, so actually it's kind of dying. And then you've got the floating muhly bush, which is just scattering around the desert. So sometimes you just need a bit of a hit, okay, for these cancers to kind of die. And this is what all these biomarkers are about. And the main thing is, what I want to really say is that we can't cure every patient, but we want to offer the possibility of cure remission to more. And the more we understand the biology of the cancer and also go with the patient journey and understand there are certain things that we need to do to make you kind of more likely to be cured, the better. So again, I cannot thank enough of my patients that I treat on trial, their families that allow me to do research, allow me to do clinical trials, allow me to do what I do every day in clinic. And on top of that, not just my trials team, but as I said, Daniel Hockhauser, who many of you in the room, but all these colleagues. And these are not just doctors and surgeons, these are nurses, okay, research nurses and nurse specialists, okay, who do a fantastic job supporting the whole team and the family. And this is the research side. I talked about the Janssen lab, and a lot of this work which I'm presenting is done by my co-PhD students and Evelyn Wong. Again, in the UCL Cancer Institute sits Mariam Al-Jamharjani, who's, I would say, the left-hand, right-hand woman, or both hands of Charlie Swanton. Sergio Casado, who does great work with James Allison, who you may have heard about at the Park Institute in Texas, but he discovered, Sergio helped him, was part of the team who discovered this thing called CTL4 and PD1, which are the immunotherapy drugs. And actually, this is very important. This is the microbiome unit at Leeds, okay, because we've talked a lot about the microbiome, fascinating work. So I just want to thank everyone. These are all the hospitals that helped with the NeoPrism trial. And if you're interested and patients do need access to GI research trials, there's a way to contact me and my team. I think that is it. Thank you very much.
Kaki, thank you so much for sharing all that with us. I mean, it was absolutely fascinating. And the thing I was sort of getting from this is the world of cancer is changing. Do you think there's going to be, when I say a cure, you understand what I mean? You know where I'm coming from. What sort of time frame do you think?
Yeah, I mean,
it looks like we're going to have an antibiotic for cancer at some time in the foreseeable future.
I mean, so that's the kind of question I normally get in a taxi, right? The taxi driver says, "What have you found a cure for cancer?" Yeah, we've sent the man to the moon. We've genomed the whole genome. You know, and I think there's two things really. There's a pragmatic point, which is really straightforward, isn't it? If you prevent the cancer from coming, that's the best thing. So unfortunately, and this is from my own heart, we haven't quite got, but we're getting there, that companies who love expensive drugs, they spend a lot investing in drugs, so that's why these drugs are expensive, are treating advanced disease for years, okay? Wouldn't it be better to prevent it using vaccines or short course, short amounts of immunotherapy, chemotherapy? But that is not really their modus operandi. They need to make the money. They need the blockbuster, and then they might let you do the indie play or the indie movie. So all I'm saying is that there's two parts. There's the pragmatic part. We as a population, as a society, should try and do as much as possible. I know it's difficult to work this out, to try and be as healthy as possible, to try and reduce the risk of you getting cancer. That would be the best way, right? Okay. And then, yes, if you've got cancer, we try and pick it up early with screening programs. And then if you've got a cancer, you want to make it as personalized as possible. So you get the possibility of being cured with a combination of not too much treatment, just right. So I use the Goldilocks principle. Yeah. Not too much, not too little, just right. And yes, there will be some patients who will need these miracle drugs, right? That put them into remission. But we hope that's fewer and fewer. Yeah. So I would far prefer to have less and less patients in my clinic, yeah, and only a few that really needs to see the oncologist, because most of the stuff has been prevented or been managed almost like a GP, not like a GP, like as if it was you living with diabetes or you're living with blood pressure and you're trying to actively prevent it. So that's not really an answer, but what I'm saying is that there is no shot. I'm very careful what I say about, even when I say cure remission. I don't think we can promise cure to anyone from the beginning, but we can offer them the best, as I said, tailored treatment that gets them the best chance of having not just a long life, but good quality of life.
That's brilliant. That's brilliant response. Thanks so much. And
a very long response.
I think the other thing is my feeling from your talk was that if you are a person who has to have anti-cancer treatment, go for a trial. Right. Yep. Trials are good.
Yeah, trials are good.
Yep.
Yeah. I'm not going to say every patient should go on a trial. Okay.
Not
so,
everyone.
but I think that I would encourage patients that if a doctor offers you a trial, have a good think about it. Okay. That's how we learn. That's how we got to where we are. Of course, there's a journey to that. Okay. And this is about, again, spending more time with the patient than just saying, here's a trial, read it. It's 27 pages long and come back next week. but that you need a team around you.
Yeah.
So what I'm saying is you should not do this in isolation. You should, a lot of trials recruitment is based on trust. And I think that's right? You're trusting someone to look after you, you're going to try a new treatment, right? That may or may not work. And then a lot of people saying, but I only want, very, very clearly, I know this is psychology, that I always say to patients, do you understand what tossing a coin is like? Oh, I hate that. I only want you, Dr. Shu, to give me the treatment X. Can't do that. Why? That's so unfair. Unethical. So I think you've got to think about that. But yes, in general, I'm very pro trials, and there's a lot of evidence that even patients who are on a trial who don't get the experimental treatment do better than if they were not on the trial treatment. Because in a trial, there's a whole team around you. You get extra patients looking after you, checking, making sure the bloods are okay, the scans are okay, your health is okay. So there's very good evidence that being on a trial anyway improves your survival.
Any questions?
I've got a question, actually. I used Dr. Shu many years ago.
You used me. Oh my God. Yes.
And I'm also BRCA2 gene, and I just wondered, should I be doing any
Well, extra.
now that I've survived and that, but I've got BRCA2? Is there anything I should be doing?
No, well, I know exactly what you had to say, Alan. Thanks for coming up to me. So I think you're very likely to be cured already. And I use good old-fashioned chemo, but because of that gene, I knew that the chemo I was going to give you probably was going to work better than for most other patients. You've got to a point in your life where I would say that the chance of you relapsing from the cancer you had is 0. So now you have to live your life and prevent. And I don't know, because I'm not, I've got Laura here. I don't know enough about BRCA because it's not common in GI. I mean, apart from pancreas cancer, I don't know yet about the preventative vaccines for that. But I can see, envision, because I really didn't talk about vaccines, but again, you can make a vaccine out of anything. That's what almost COVID taught us. If you can make a COVID out of a spike vaccine, you can make vaccines out of anything. And the question is, it's called the Betamax versus VHS, right? It's like, which one's better? They're probably quite the good same, but who's got the best marketing? Who's got the best quality? So all I'm saying is that I don't know for you personally. I don't know. I mean, honestly, I think you're living a good life. Exercise very important. Eat a healthy diet. But I don't know there's anything specific for BRCA2 carriers of your type to prevent secondary cancers. I don't know. Okay. Maybe not knows.
Screening.
Yes.
There's sample, and your wrinkles.
Yeah.
We're good today, but anything can happen in the next 6 months, year, 2 years, and I'm sure we can bring it through.
Yeah.
I've seen, when I work here, so I've seen people that have done various screenings and various things, all good, and then suddenly they found breast lump 3 months later, it was not picked up. They suddenly had pain, it's ovarian, nothing, but they had a CA1 checkup and wasn't picked up. How long are we saying in between these screenings is a really, obviously we can't have these things daily.
Yeah.
But one can get, okay, for now, I feel safe.
Yeah.
What's the strain?
So I'll keep in my lane about, let's say, bowel cancer. So, and Darren's here as a surgeon, and he'll have many pictures of stories of people who may have had what I call misdiagnosis. That means that you have a colonoscopy, you thought it was a great quality colonoscopy, everything was fine, and said, okay, I normally, unless it was completely pristine, depending on your age, you might say have another one in a year, 2 years, 3 years, 5 years. Okay. So let's say the whole point is we are understanding now that this concept that bowel cancer takes up to 10 years to develop is true for some patients, but now, especially in this early onset, we think there's this kind of, it can have an accelerated growth. Okay, so it can be, you can get a normal colonoscopy to cancer in 3 years, and I've seen it. And this is not because of misdiagnosis, this is true biology. And so the concept of what I'm trying to do with these kind of programs is how to work out which patients are okay to say, you're going to be okay for 5 years and you just haven't done it in 5 years. No, you're not okay. Even though the standard scope says you're normal, you need to be scoped at 1 year because your microbiome says your bacteria are not good. Okay. Something about the genetic profile or another liquid test or immune test says there's something not quite right. So we're all trying to do that because, as I said, screening is as good as the test, and then also the implementation of the test for each individual. Because remember, a lot of screening is population. You as an individual want to know, I don't care about the population, I just want to know about me. But that's a really good question.
Okay, thank you.
Was that a question?
Yeah.
Yeah. Sorry, I was trying to cut down my slides, but yeah, so absolutely. Unfortunately, it kind of makes sense that if you have a continuous inflammatory kind of disease, yeah, you're more likely to get abnormal cells developing. So I haven't really talked about it, but yes, I would say forget all the other genetics we've just talked about, you know, family genetics. But if you have Crohn's or arthritis, is anywhere, if you look at it, anywhere between 2 to 5 times higher risk of getting cancer. Now, that doesn't mean that, remember, the absolute risk of getting a bowel cancer is still very low. Okay, so it's like 5 in 100,000, whatever. But then it still adds up. So we do have actually very specific things. If you are anyway in a Crohn's clinic, or then you're obviously being looked after by gastroenterologists who should be scoping you. Okay, and the main thing is to make sure. Sorry. Oh, you mean how? Yeah, I mean, actually, I'm not sure of those guidelines, because obviously I don't really get involved in that, because it's, you know, they're very specialized. But if you need, I can come, I can talk to you now, because St. Mark's Hospital, I don't know, in Harrow, is a world-class center. So they have loads of guidelines of how long you should be scoped for and how frequently. But
Okay.
you can, I'll talk to you later.
Go over there, and then over there.
No. So I want to say celiac is not the same. So there's ulcerative colitis and Crohn's. Celiac disease is a completely different issue.
Okay.
Unless you have very bad gluten, I mean, as in you ignore the advice, and you probably get very, very bad diarrhea. But yeah, it's totally preventable if you take the diet.
Gentleman over there.
Small bowel symptoms and they get scoped. My story is that I had colon polyps removed, and I, 22 of them, I'm being referred to St. Mark's and Middlesex for polyposis clinic. And we talk a lot about all the lower GI. What about upper GI? Do they want to recommend gastroscopies and things like that?
Yeah. Yeah, so I do treat gastroesophageal and small bowel cancer as well. So if you talk about small bowel, that is quite a rare. It's really actually pretty rare. So that's not helpful. You say, okay, it's rare, but it is felt to be a very rare cancer, and they're quite hard to diagnose. And you know, but there are ways to do it. So we have talked about obviously endoscopies, but you can only go so far. So there's something called capsule endoscopy. So you swallow a video camera essentially, and you pass it through your bowel. There are special cool dynamic MRI scans, right, where you can actually look at your small bowel. It's like a amazing picture where you can see your small bowel moving, and these radiologists are amazing. They can work out that movement is not right. There's dysmotility, okay, so that could be an area, and then you could detect it. So that's small bowel, but that is super rare cancer, and we have to think about that. Actually, stomach is that it's very interesting. There is no screening program at the moment, okay, for routine stomach cancers. Yeah, there's something called Barrett's esophagus. Have you heard about it? Where you got a lot of information and you followed through. But we don't have a screening program like in Korea or Japan, right? Where you know why they get a lot of cancer? It's because they drink a lot of tea, hot tea, and they scald their gut. I thought we drink a lot of tea in Britain, maybe not as much as we thought, or not as hot. So we don't have a screening program. We probably should, but there's a lot of work. There's a lady called Rebecca Fitzgerald, okay, who uses cytosponge. So basically, rather than being scoped, you think that having a colonoscopy is bad. I mean, having an OGD is horrible, okay, because it's like coming right at you, right? So they do the thing where you swallow a sponge, you literally swallow it and you pull it up, and then you can see these tiny cells. So this is a way of screening without going through a very invasive test. So we are getting that.
Okay. At the back.
Is there anything with, what age would you start? I don't know, children.
Yeah.
So.
Yeah. Okay. So I'd say that in general, the advice is that whoever you're, so let's say you were 60. Okay, no, I mean, the way to think about it is that if the grandfather was 80 and the father was 70, then, you know, you say there's a family history of cancer. But it doesn't necessarily mean that you have to have a scope when you're 25. Okay. So the piece that I'm seeing is that if you're 55, yeah, you tell your kid that your dad or your mom or your auntie, your uncle had cancer. And the story for me is I'll tell you a personal story. So I've had scopes because my uncle, born in war-torn China, in early 40s, then went to business school and then went to America, died of metastatic bowel cancer at the age of 45. He had what we call metabolic. I'm sure it was because of the diet he ate. He was so unhealthy, right? His body probably didn't cope, and he got metastatic bowel cancer. So we all started getting scopes at the age of 40, right? Nowadays, you'd say get a scope at 35. I mean, it's not. I'm lucky, but this is the thing. It's still the 10-year rule. Now, with some of the research I'm doing, and there's you may have the Galleri test, which is like trying to find tiny cells to detect early stage cancers. We may have those tests, though it's like a little bit like not sure which way we're going. But we might have these population screening tests where we do a blood sample and say you are at risk, okay, of getting cancer at this age, so you need to start screening at this age.
Okay, last question, please, sir.
Comparative types of diet food, for instance, vegans and vegetarians, but people eat 5 types of food today.
Oh, gotta be careful what I say here. I think all I'd say is that fiber is good for you. Okay. So,
piece of food.
sorry, fiber, just generally, yeah. So eating fiber, eating a variety of fruits, and colors. Apparently, it's all about, it's not just like eating green stuff, right? So I think that I'm not a nutritionist, and I'm going to be really careful what I say. There's some really good books out there, both from phytology people and some very scientific people. But all I'd say is that in general, fiber is good for you. In terms of something called Lynch syndrome, we talk about these kind of unmodified starches, green bananas, all these kind of things, unmodifiable starches, which are good. But they're all kind of common sense in a way. So what I say is, and this sounds very trite, but it's always moderation, and everything in moderation, including moderation itself. Okay. So I am not asking you to be extreme in any of your diets. And I think generally extremes are bad, right? But sensible, everything in moderation makes sense to me.
Yeah. Thank you. Thank you for that. Kakin, again, thank you so much. I mean, I appreciate there's a lot of grayness in this conversation, but I think you've opened up our eyes to there's a lot out there. There's a lot of changes happening. There's a lot of things that we can do to help ourselves, as well as things that you can do, if you see where I'm coming from. And we are so grateful that you came to give this talk. And Kai, Keen, thank you so much.
Thank you. Thank you.
Thanks to you, Kai. That was absolutely
Thank you.
fascinating.
I enjoyed it. Yeah, that's good.
Interesting to hear about the clinic you've set up, or in the process of setting up for young adults.
Yeah.
As at Kai, we're also spending a lot of time developing services for young adults. So we look forward to
Great. Keep updated.
more on that. And just while I'm here, I'd like to say,
Sorry about that.
I don't push it. I'll hold it. Just a huge thank you to Louise. Thank you for your lovely words earlier, and generally for being an amazing human being and for supporting me ever since I got here. And while you're here, I just want to say a big thank you to all of our staff, our amazing teams here, all of our practitioners, all of our volunteers who really put so much effort and so much hard work and care into helping each one of our clients. So thank you all for coming. Please help yourself to drinks, pastries, and stay and chat for as long as you like.